So welcome everyone to the second Game Changer seminar for 2024 and welcome to those people online as well. We're delighted to see as many as that are here today, and it's great to have you, and welcome to all those clinicians who've been able to make it in person or online. Just moving the slide on. I'm trying to anyway. Okay. On behalf of TRI, I'd like to acknowledge the traditional custodians of the land that we're on today and recognise their continuing connection with land, water and community. We pay our deep respects to them and their cultures and to elders past and present. So it's a real honour to welcome Professor Jenny Martin back to TRI today. Almost 10 years since you left these parts of the world to pursue your career south of the border. Jenny has an amazing list in her CV of achievements. She's the current president and chair of the Royal Australasian College of Physicians. I don't know how anyone convinced you to take that job on. She's a clinical pharmacologist and physician and chair of the clinical pharmacology at the School of Medicine and Public Health at the University of Newcastle. In addition to that, she's director of the University Centre for Drug Repurposing and Medicines Research. She's director of the NHMRC Centre for Research Excellence in Cannabinoids, and also director of the New South Wales Cancer Council Pathways Program, PREDICT. In her role as director of PREDICT, she's brought together a national team of clinical and science pharmacologists and oncologists who are now working with international groups to undertake research into efficacy, safety, cost effectiveness, and feasibility using individualized dose and drug choice in clinical practice to improve cancer outcomes. Today, she'll speak about equity and access to health, her reflections from a philosophical, political, and economic perspective. Please join with me in welcoming Jenny to TRI today.
Thank you. Kia ora. I'd just like to note that I'm standing on unceded Indigenous land, and I am absolutely delighted to be back. Thank you for the welcome, Scott, and for all of the team today, and great to be seeing familiar faces. I was reminded actually of how far ahead we are on equity in the TRI when I walked into the bathroom and found there was rooms actually for expressing milk for breastfeeding mums, and reflected on the journey of being a physician and sitting on the public hospital toilet to express for the pump, because it was no maternity leave and we lost jobs if we didn't turn back up to work straight away with young babies. So lovely to see that in your bike area. The plants have all grown a lot in 10 years, but really great to see the green focus. So as you've heard, I'm a physician. I work in general medicine and clinical pharmacology, but what I've become more interested in is actually something that was part of me before I even became a doctor, and that was really looking at how do we improve access to health. I grew up in Aotearoa, New Zealand, very aware that there were people that couldn't get access to health because of the parts of the country they lived in, or because of their ethnicity, and a whole lot of other reasons as well. And I thought that being a doctor would enable me to address some of those issues. But going through a 6-year medical program, realised that probably in the care that I was giving individual patient, I probably couldn't do what I needed to do. And this burned at me for quite a bit, to the point where I decided I needed to go away and actually get skilled in the areas that I could see were really affecting access to healthcare. And they were philosophical, ethical, political, and economic aspects. And all of those had a role in deciding which patients got access to which care. I can't say that 35 years on, we've actually improved equity in either New Zealand or here. And in fact, the inequity gap has actually increased. So it's made me think that actually I probably do need to up my game a bit and actually to work more broadly and think about, particularly from a health or from a medicines perspective, which is my area, what can we do? So you can see on the right, there's a picture of lots of people graduating in Oxford. During COVID, we had the opportunity to regroup and just find out what people were doing, and actually our class of people that were actually pretty privileged, even though the scholarships are available to people across Asia, African subcontinent, South America. Most of the people that take those scholarships have got a lot of support back home, and they were all actually working in the area of global health and improving inequity. And we teamed up and did a lot of work, and there's a lot of things going on globally. So that's one good thing. I took on the secretary of the scholarship selection panel because actually it's very hard to change people's behaviour once they're already in the system. So we thought that we would consider what sort of scholars that would be good leaders for Australia going forward, and how we could actually change the selection panel to ensure that we were aware of the bias on there, but tried to make it as diverse as we could. And that's the middle panel, a lot of women leaders there. And we have some people of colour, but also, most importantly, not just people that have a law degree from Sydney Uni and whose sons and grandfathers also had a Rhodes Scholarship. So in my 6 years as secretary for that Rhodes Scholarship New South Wales, we, I think, really changed the way that we thought about what makes a good leader in this area, and really delighted to see the diversity of scholars from New South Wales, but also actually across the nation over the last few years. It's fabulous, and they are future leaders. And just on my left, my colleague, who's infectious diseases physician, David Murdoch. We worked together in Christchurch for a long time. He was the Vice Chancellor at Otago, and that's our list of Otago Rhodes Scholars, but talking with him about how physicians can actually make sure that we keep true to the cause and use all the leadership opportunities that we've had to ensure that we really don't forget about equity, and it is our duty to actually make a contribution here. So I wanted to bring that up because I sort of feel that my part of the career, I can keep doing my research and my teaching, and I'm really enjoying that and my clinical work, but actually we've really got a lot of very big challenges, and we need people to actually step up and to lead some of this work. So I thought I'd just start by reminding us that actually the distributions of benefits across our people are actually from our culture, laws and institutions. And they really dictate our political preferences as well. And although you might have some choice at the ballot box, actually it's our culture and our laws and our institutions that are already deciding how we spread our resources and how we engage people in a political debate. So in a way, if we really want to fix an equity issue, you can see where we've got to start. It's probably not at the end where we're seeing a lot of health issues, but it's actually being mindful of our society's culture, laws and institutions, and making sure that we can think about how to make a voice for equity there. Particularly in health, we have this discussion, and it's actually fascinating that we're hearing a lot of discussion about the way we spend our funds in health and how we prioritise that. But again, there's a lot of bias there. There's a lot of bias because we have a colonial health system. We have a system where we have different people with different skills that have different roles. And that's all very culture and gendered and based on a whole lot of political and economic beliefs that many people have grown up with. That's not always in alignment with the Hippocratic Oath, and although that's a discussion for another day, or the way we're taught to look after patients, nor the resultant allocation of healthcare resources. I think we're kind of stuck in that system a bit, but it does struck me quite commonly when I'm talking to my oncology colleagues about why our state formulary can't provide them the oncology drug that they want to use for their patient, that this is not just about advocating for a patient in front of them with a drug that may or may not work. It's the fact that if we use this drug in your patient, which actually hasn't got any evidence, it's an opportunity cost for all of that money to be used in other healthcare across the state, for example. And it's quite common that my colleagues will say to me, but I have to advocate for my patient. and we talk about the Hippocratic Oath, etc. But there's never this discussion about the fact that as a leader in health, I've actually got a duty to ensure that I use public money appropriately. But more recently, and particularly with COVID, when we couldn't have all the things that we wanted, we actually started to have this discussion. And I was really delighted to be asked by New South Wales Health to set up a statewide formulary to decide which drugs we're actually able to use within the public health system of New South Wales, and to have those discussions with my colleagues. And actually, a lot of them got quite heated about why people weren't allowed to use the drugs they always wanted to use. So I want to just think about that with how this plays out in Australia, because I think for most of us, we get on with our day, we wake up and go to work and go home. We don't really think about the fact that we distribute resources based on our society's culture, laws, and institutions, which I know from being in my college role now that actually, we've been accused of being racist, actually. So our institution, the Royal Australasian College of Physicians, a great colonial institution, is thought to be racist, not just by patients, but actually by some of the physicians that have come into our college and have grown up in places other than Australia. So I think that we are getting a real awareness here. And our access to pharmaceuticals is a really good example of this. So how do we make decisions on who gets public funding for drugs? If you're wealthy and you can negotiate access to the minister, or you can negotiate access to a pharmaceutical company, you might be okay. Or if you're a particular racial group, for example. But there are a lot of people that don't have that access, and potentially there's still resources that are used. Even if you fund the drug yourself, there are still resources in our public health system that are used there, and they're not really all that fair. So I guess if I just, I wanted to dismiss some myths. I realise the time's moving on and maybe I'm taking a long time here, but people say to me, oh, well, that's irrelevant. You're just an ivory tower academic. But actually, we've got a great democracy. If they're not doing things fairly, we'll just vote them out. And I'm looking at them thinking, really? You tell me an example of when you voted somebody in for something and then they've promised that we're going to improve equity of access, for example, vaccines to regional areas, and that hasn't delivered, and people start to realise that this is probably just a myth that they've grown up with. I like to think we've actually got an elected dictatorship. So essentially when an election comes around, we have a choice of one or two or maybe three parties, and we make the best of a bad decision and make a choice. And even if the people we've voted for get in, essentially that's it. We don't hold them accountable. We don't have access to people in the way that we think that we ought to. And actually, once a policy's on its way, it's very, very difficult to reverse that. So I think we should just think about whether we have got democracy, and maybe we have, because we've all got a vote. So in some ways we have, but our processes are maybe not all democratic. And that's where the decisions are made about who has access to healthcare resources and how we deliver them. So I think we need to just reflect on that, who has access to power and how we make decisions. And look, I know this is being recorded and maybe I'll lose my job after this, but I did just want to note, because I have got the floor and a microphone, that we have a really big problem in Australia with some of these big lobby groups. So my area is pharma. I don't know how many times I've actually had to call the farmer's bluff when a threat has been made to me that I haven't listed their drug on the state formulary or wherever, because didn't I know how great their drug was, and if they don't list it, there'll be legal action. Me then sending back a 2-page dialogue summarising all the data and saying, yep, happy to take you on this, and finding that the case has been withdrawn. So that's my area of big pharma. But that's, for my colleagues, they are stressed by this. This is very confrontational. They don't like feeling like, particularly as physicians, it's not our comfortable place to be. But let's just say, if you don't even feel like noting the role of big pharma, let's just think about the fossil fuel industry. How much do we give in subsidies to the fossil fuel industry? About 10 billion a year. So, that could wipe out all of our, we've all got kids, that wipes out all of their HECS debt if they particularly want to go to university. So why are we not fighting on that? Do we really have a democracy? And how are decisions actually made? The beverage and food industry, well, I'm going to talk about obesity later, but, we've got an obese population that's increasingly big. And do you know what? We can solve it by using big pharma to give us a drug to help us lose weight. So everyone's a winner, but not the public health system, and not actually the people that can't afford the solutions to the problems that have been created by our big lobby groups. We're also the only democracy without a Bill of Rights. So need to think about that. Even New Zealand doesn't have a constitution, or not a written constitution, has a Bill of Rights. It seems to be like that's a pretty basic thing to have. And despite 25 years of economic growth, jobs and growth, we hear about that a lot. We're not really all that happy, are we? And we certainly haven't closed the gap. It's huge, and our inequality markers generally are rising, and I think we all need to step up. So when I'm thinking about getting through my clinical list in the morning, my other thought is, I need to do something that really can improve health here. So how does this all affect health? I mean, people say, oh, it doesn't matter because if you get sick, you just turn up at the public hospital and they'll sort you out. But actually, we know that's not true. And if you look at the Australian Commission on Safety and Quality's Atlas of Variation, you might get quite a shock into who has access to what interventions, what pharmaceuticals, whatever. It's got everything on it. And it's fascinating and gets repeated every few years. You can actually see what's happened to the variation across Australia in terms of access to health. So I think these are big questions that we need to have, and I'm really delighted to be here in the Translational Research Institute because you are the Translational Research Institute. You've got really good people and energy and facilities and research. That it's an opportunity for us to think about what we can do here. I had a little note there about Medicare and its distortion. So I think Medicare was set up for a reason, 50 years ago. Now we know that in specialties such as geriatric medicine, where we have a huge healthcare need, and Indigenous medicine, where there's a lot of comorbidities, people aren't, the doctors that give the care for that aren't necessarily covered for the cost of their time for that or general practice. We tend to fund people who do technical skills. So if you can do a bronchoscopy or endoscopy or an orthopedic surgery, that's funded pretty well through Medicare. And look, our hospital funders have been known to talk to physicians like me and say things like, well, it appears that you're costing the hospital more in your salaries than actually your department is bringing in Medicare rebates, which is just a fascinating discussion, really. And it really is a good trigger for me. And I actually get pretty stuck in on that. But I think, these are distortions that have been set up by powerful groups, and we probably need to have a look at that. Climate and health is something I want to talk on now, because I think these are another examples of where we're seeing inequity and we're going to continue to see inequity. I mean, all of us are affected by climate change, increasingly so, depending on whether you live in a coastal area, whether you have asthma or other health conditions that are being affected by the warming of the climate and all of the carbon emissions that are out there, but significantly more in vulnerable populations who can't necessarily move from coastal regions that are getting flooded, where people can't actually fish for food, and people that work somewhere close to Beetaloo and Middle Arm, which happen to be in Northern Territory, who don't have any control over the fact that the volatile organic compounds that are released don't have any upper limit on them. So we're poisoning our own people's health. The ppm's greater than 2.5, again, these are causing huge amounts of harm to our patients, and we know they cause cancer as well. So I think we should really think about where we are in terms of that space and whether we have got a role in advocacy. And I feel people's concern about that and anxiety, and even in our own college, people say, oh, we're physicians, we write policies. And I'm saying, yeah, but we're all going to die unless someone stands up and actually advocates for health. And I think that we should be doing this. So I live in the Hunter. Disaster already unfolding. 15 years ago, we knew that we had significantly higher rates of hospital admission for cardiorespiratory conditions. And we've just got a new report. This is Tracy Ferrier in our local newspaper, August 2024. And we're really in big trouble here, all of us in the Hunter. Everyone who's got children who runs around playing soccer or whatever, and we need to do something. So I'll talk about what we're doing locally in a minute, but I just wanted to reflect back on this, that the healthcare industry has a significant impact to the environment. And if we care about inequity, we've got a duty to look at our own industry and think about how we can actually reduce emissions. We have New South Wales Net Zero within our health department. They are doing a fabulous job. Although they've only been set up for a small period of time, they've actually made incredible progress. And we've actually got a national health climate strategy. I'm not sure if any of you've read that. Just look at the front page if you don't want to read the whole thing, but it's absolutely fabulous. The College of Physicians actually did put into that, as well as a lot of other jurisdictions. The issue we've got now, though, is how you implement it. So we know what we should do and what we have to do, but how do you actually get people to stop using metered-dose inhalers, for example? Or how do you get people to stop using a whole lot of throwaway surgical drapes after each operation, for example? This is just to sort of lighten us up. There's a lot of words on those other slides, but I just wanted to point you to this is a comparison of CO2 and ice cores over a period of time. And you can see that for millennia, the atmospheric carbon dioxide had never even been above that 300 line. And you can see where we are today. Hopefully you can see up there. So we've sort of been pottering along here for a long, 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 long time. And then suddenly we're here, 1911 is there, 1958, and we're here. So, there was loads of stuff on this, on the NOAA. It's an oceanographic site. So have a look at it and you might be quite shocked because I was, but I had to move on, but there's a lot of stuff there. Now, the CDC, people think of America as big polluter. Actually, they're doing quite a lot. And the cdc.gov website is just fabulous. And we could pinch a lot of stuff off them, I think, because they've actually called a principle, a JEDI principle, which I love. So we talk about EDI, but they've added justice in that. And I think justice is really important and certainly important from Indigenous framework. So you have a look at the CDC website, and this is just a graph I got off their website. They have a lot of them with actual numbers on them in terms of the actual impact this has. And as I said before, our Indigenous lower socioeconomic groups, vulnerable people like elderly, are way more affected than people who don't fit those groups, even though it's going to affect all of us and is affecting all of us. So it's pretty big. I mean, even the changes in vector ecology, you know, the fact that we see malaria, the fact that we've got monkeypox, you know, this is all sharing of land with animals that we never used to do, deforestation, et cetera, et cetera. So it's very important to, and I think I was just saying to Dr. Bell before we met that I'd met with Linfa Wang, who used to run an arm of CSIRO, but now runs the Singaporean pandemic response unit. He's a bat virus person, and he tells me he's never been so busy. But essentially, bat viruses, you know, SARS-CoV-2 circulate in bats and other mammals for a long, long time, no problem. But once we start sharing environments, then a lot of those mammalian viruses actually become a real threat to us humans. And you've got viruses here, the Hendra virus and other similar viruses which cross from animals to man. Okay, this is Professor, so people say to me, yeah, whatever, Jen, it's so overwhelming. I've just got to do my job and go home. What can I do? And I think you just got to do something. It doesn't really matter what you do, even if you change from riding a bike to taking the bus. It's just, I think we do have to absolutely get on with, yeah, how do I click on that? On here. There's a mouse thing on there. Oh yeah, thanks. Hello, I'm Jennifer Martin. I'm a physician and a clinical pharmacologist. Our work involves medicines and involves clinical trials and ensuring that the drugs that we use work effectively in the people that need them. One of the issues we've had in Indigenous health is that we make medicines policy without the consultation with Indigenous people and often without Indigenous data. That means that what we actually see in practice is that people suffer because they don't actually respond to the drugs in the way that we expect them to. For that reason and many others, I think it's very important that we have consultation with our First Nations people, because I think that there's a lot of experience that shows that really improves health outcomes, and particularly in my area, which is medicines policy. Look, I just said that because Nick and I basically were having a coffee at lunchtime. Nick Charlie, previous president of the college, senior gastroenterologist in the Hunter, and he's now the chair of the DEA, Doctors of the Environment. But we were both sitting there one day thinking, what can we do? It looked like we were going to lose the vote for the Indigenous referendum. And we said, no, let's go out there and make a Zoom, a YouTube, or we'll just post it. We didn't think about getting permission and whether we could speak as New South Wales health employees. So I think all of this stuff comes from a good place. But the issue with that was that it kind of went viral. And we got a lot of questions about whether we, here's two senior physicians from New South Wales Health. And yeah, I think we just have to, we'll be speaking on behalf of ourselves or whoever. And I said, look, it doesn't really matter. Someone's got to step up, and we really need to get this Indigenous voice across the line. And it was not really anything that was too complex. It was just about that whole point I raised at the beginning, that if we're making policy for people, and it's around equity, we need to consult and we need to make sure that voice is there and do it properly. So I'm hoping that we at some point get another opportunity to bring that important Indigenous voice in. The other thing we can do is just leadership. I mean, I think innately we're all leaders, and you might not know you are, but you are. And sometimes you have to wait for the right opportunity to step up. But I think when that opportunity comes, it's important to use that. And look, I mean, you might think that I do talk a lot, and I am quite lippy actually. But when I was in the Hunter, I was pretty busy raising my kids, and I've been quiet for a long time. But I was a staff elected rep on the University Council. And you might remember this is during COVID, and suddenly we find out that the new Chancellor, who's been appointed on the council on which I sit by unanimous vote, is actually the chair of Whitehaven Coal, which is actually the biggest coal mine in New South Wales and actually a major polluter of the Gomeroi people's land. Now, we also say in University of Newcastle, don't worry, I know I can't get sacked because we've already had this conversation 4 years ago, that you can't have a strategic plan in the university that says you support Indigenous people and then have the Chancellor as someone who's polluted Indigenous land. It's kind of a bad look. Anyway, I sort of had two options. I could either suck it up and sit on the council, or I could leave. So I thought I'd leave. And then I found out that I might lose my job. So I thought, well, if I'm going to lose my job, I'll just tell everyone why I resigned. And I had all of this just frustration and irritability of the fact that we talk about equity and then we go and just do something else, that it all sort of came up. Anyway, it got in the paper, and then the doctors at the John Hunter decided not to teach medical students for the university because they didn't want the university to be led by someone who is pro or anti-health. So we had no teaching. I was sitting at home just thinking, what have I done? The students rang me, they wanted to run a protest. Could I lead the protest? And I thought, well, why not? Because I can't really go to work. And so here we are marching down Hunter Street. I've got this megaphone. And anyway, who should turn up in his nice car, in his EV with a suit on? Professor Nick Talley, who gets out, takes the megaphone, says, I'm a physician and I stand for health. And if you're a doctor and you're not here at this protest, then you're not really a doctor and you don't care about health. You know, it's fabulous. And we got so much support from the local community, which is amazing. It's a fossil fuel town. Our university is funded by fossil fuels. Our HMRI has fossil fuel money. But there we were, the two of us, not knowing how we got there. But anyway, then the donors decided they would pull out money of our university unless they withdrew. So this is myself and Richard Dennis, who's head of the Australian Institute, then took the opportunity 5 days later to write something for Insight, which they published rapidly, which is very good of them. I guess considering that Charlie was actually the editor of the journal probably helped a bit. But I think that we really had that opportunity and we used it. So we made the AFR, and I thought that was quite good work, considering the AFR usually supports fossil fuel industries. We had a lot of support from the education editor talking about, well, who even sits on these councils of universities? And actually, we found out that a lot of the people on the councils were fossil fuel people. And actually, for an education institution, you would think that you should have some people on there who understand the business of the organisation. So this went on and on. Here's me and Nick Talley doing more, feeling quite emboldened, I think, that our colleagues had actually supported us. And this is the AFR article, which you can look at last time, but just a couple of quotes out here. I said that the appointment did not align with the university's strategic plan or its commitment to the Hunter region's economic transition away from coal. Another person said that the appointment was tone deaf. The message from the city is about transformation, transition, and development of new industries, and declining demand for coal would at some point leave Newcastle as a stranded asset. And the editor also wrote that this person didn't have any connection with the universities or how they work. So I think that, and actually it was quite nice that I had been pushing for an Indigenous person or a female to lead the council. And I think we have got a female chancellor, but I think we probably need to do more as one of the biggest Indigenous areas in that part of the coast of Australia. So I've already said all this, but I think we're now getting to see that it is our culture and our laws and institutions that dictate how we distribute wealth and benefits across the people. And I think, you know, a university of all places should be the place where you can speak up and actually speak have academic freedom, I guess, and speak in that way. So my area, got a few minutes left, is pharmaceuticals. I think it's another example. But just if you can think about who gets access to medicines in Australia, how they get access. I mean, I've had patients myself who have wanted to use something that's just a new drug. It doesn't really have any evidence, but they want to try it. And how much resource we spend trying to access that for that patient. And then I think, wow, I wonder if this person was in a rural area or a regional area, would they have the same access to a physician that would be able to negotiate this for them? I did just want to point out a couple of examples to show how affected by industry we are. Actually, at this hospital where I used to work across the way there, we had drugs for osteoporosis. Now, that's a big ticket item for Big Pharma. Some of these drugs really weren't that effective compared to the existing therapies we have, but they're very expensive. But the company, Roche, was actually able to fund what was called osteoporosis nurses. Now, those nurses would go around basically making sure that everyone who had a fracture got access to their drug. Now, you might think that that doesn't taint the way you think, but I can tell you that we know what happened with prescribing of that drug. We also know what happened with outcomes. And it's not necessary that you give a drug to someone and they get better. I want to talk about Pharmac. That sort of gives us another example about who gets access to medicines in Australia. There's a website I'd like to show you, but New Zealand was founded on the Treaty of Waitangi between Indigenous peoples and the Crown. And there's certain rules, pillars in the treaty around equality, and which is slightly different to equity, I know, but I think this has been introduced into all of New Zealand's policies, but it's not been as easy as it sounds. It sounds like a good idea, but really, I didn't have a slide on that. Sorry, if you look up the Pharmac website, you'll see this thing called factors, which is all the factors that are taken in consideration when a decision is made on how to fund a drug. So it's obviously efficacy, safety, and then a whole lot of things about ability to benefit. Anyway, you'll see that if you go on the website. New Zealand had a problem though, because it did things like, for example, very expensive diabetes drugs that might lower your glycated hemoglobin by say 1% or 2%, which might be not much in the general population, but if you're really overweight and from an ethnicity where the HbA1c might be significantly high, dropping it by 1 or 2% probably doesn't make that much have that much impact on outcomes. Anyway, the decision from Pharmac was not to fund it for New Zealand because it was very expensive. The benefits were not thought to be that great, but it ended up being funded for a particular ethnic group. And the reason for that was, even though we didn't have any data in that ethnic group, even though the benefits would be small on the whole sort of overall management of this patient group, there was awareness that this particular illness affected one of our ethnic groups significantly, and therefore they should have access to the drug. Now, people like me were standing up saying, well, if you've got a problem with the fact that we're really obese or we have too much diabetes or heart disease, we need to actually fix the causes of that problem, not just give someone a very expensive drug at the end of that, because we don't really think that's going to change outcomes very much at all. So there was a bit of a backlash in New Zealand. We have been doing some work in pharmaceuticals also in New South Wales, which is my jurisdiction. We set up a formulary just to say which drugs should be available, and equity is a big issue for us. So we make sure that the drugs available at the Sydney metros are also available across the state, and we didn't previously have that because the hospitals had to purchase their own. So big cities with big populations could purchase Sagamedex, for example, but in the Hunter we couldn't afford Sagamedex because we didn't have a very big population. But we did this, we set the formulary up, reduced the number of drugs available for use from 7,000 to 2,000. And actually we think we've had better quality care, but we're still waiting to collect. It's only been up for a year. We're still looking to collect some of the data there. But what we have done is partner up with New South Wales Net Zero and use that platform to also not list drugs that were bad for the climate. So we've got rid of desflurane. Nitrous is under consideration. I know you're looking at that here too, and metered dose inhalers. So I think there is ability to do this if people are committed to changing the way we make decisions, to changing the standard societal constructs on distribution of resources. And I don't know, I put this reference pricing one up. I just wanted to show that I have been in the space for a long time, thinking about the way decisions are made by government, made by committees, and whether it's actually in our interests. I might just move on from this one very quickly. We're using old drugs in cancer and finding that actually if we get the dose right, we can actually improve, this is with 5-FU, for about 60% of patients, we're underdosing with 5-FU, and we've actually got good data showing the relationship between exposure of 5-FU and clinical outcomes. So 5-FU is very cheap, but if we can improve clinical outcomes by using those drugs properly, we can actually achieve a lot for not much money. So these are the discussions I think we need to have. I've just actually found the New Zealand Pharmac slide. Fabulous. Okay, so if you go on New Zealand Pharmac, you'll find the equity slide. This is how we make decisions. So the health benefits, costs and savings, suitability and need. Anyway, sorry that that's a bit out of order there, but I think it's fascinating. It's very different to the way we think about accessing pharmaceuticals here. So I think I've just got a couple more slides, two or three more slides to remind us. I've had this slide up a couple of times, but I just want to make sure that we're really clear that we can improve equity, but we have to look at who makes the decisions and how the resources are allocated and what framework that's based on. What set of assumptions? Do we think it's merit-based? Do we think it's equality? Do we think it's ability to benefit, etc.? So this is actually really my last slide here, I think. Got it. Yeah, question slide. I put this on. I had another sort of end slide, but then I was thinking, did any of you see a Q&A the other day with Joseph Stiglitz on it? He was talking about all the macroeconomics and inflation and employment, and some of those common myths, like if you actually pay people a minimum wage, then you'll get higher unemployment. Anyway, it was great because all of these, they were pretty right-wing sort of statements without evidence. And Joseph, who's actually a Nobel Prize winner, who spent his life basically doing research on this area, basically poked holes in it, that actually you can provide a minimum support level for people and also improve engagement in the workforce and improve growth. So if you haven't looked at it, you can probably get it on ABC as Q&A just a few weeks ago. I mean, he's written some really good stuff on the importance of economic justice to the survival of democracy. So economic justice, we don't have that here in Australia, but we could have it. We have it for some people, but not everyone. He's also described the climate crisis as humanity's World War III, and he's written some pretty cool books. His latest is People, Power and Profits. And a lot of, I mean, we've spoken about some of those points today from an Australasian perspective, but I think he's got a lot more data and evidence for that. And I think working in health, health's kind of like the end product when you don't actually sort out these distributive justice issues. So I think we probably need to think on that. And I just would like to finish by encouraging people to read widely. We know that even though we're a democracy, we don't necessarily have free media. There is some media that's very good, and you need to find that and make sure that you're properly read. I think you need to think widely and turn up to conferences which are not necessarily your little craft group, because I think it does broaden the way you think about health problems, and discuss widely. And I think we do need to be courageous. If we're employed as public servants, we're paid by the health system or in the universities, we are leaders, and we do have that responsibility, I think, to use that to improve health, and we know that will improve society. And really this whole idea about ideas, we do need to do the research. I think the arguments are much stronger with research, and I've actually seen that with the Professor Tully and the Doctors of Environment, that he's actually got the data on the harm this is doing to our health. And it's very, very powerful for media to be able to show what damage we're currently doing to the health of our people, and ensure that if you get an opportunity to help translate that into policy. I know our universities don't recognise this in our sort of KPIs and our portfolios. They like us to publish papers, but actually none of that has an impact really. I mean, maybe some of you got some papers that have had an impact, but in my university role, I often look at this and see what's happened to people's work, and most of it's uncited. A lot of it's not reproducible, and really it's never used to actually generate something good going forward. So I really think even if our organisations and our employers are not able to think like this, we absolutely need to be focused on using our position to improve society, and I think as health people probably to improve health policy. And I'll finish on that point. Thank you.